Ladies and gentlemen, my name is David Castro Diaz, and I have the privilege of introducing Professor Andrea Tubaro from Roma University, who is going to present on controversies in benign prostatic hyperplasia. This session is being broadcasting to the ICS members who are not able to be present in this meeting. Andrea, please. Andrea is a professor with very well-known urologist, and I'm sure he's going to give a very nice presentation.
Mr. Chairman, ladies and gentlemen, members and guests of the International Continence Society, good morning. First of all, let me thank my chairman for the kind introduction and the scientific committee for the honor of giving this lecture. I won't present any data about the outcome of treatments of BPH because I'm sure that all of you know very well what has been published. This is just a number of thoughts that I had over the last 30 years about prostate surgery and the issues relative to this kind of procedures. When you feel like you blame me for showing poor quality data, I think we have to think about blaming ourselves for not doing the proper study. Many years pass by and we still have many open questions. These are my conflicts of interest. So when in theater and I have a patient entering my theater for BPH surgery, one of the questions I have in my mind is, how did the patient ended up in theater? Because if I think about 1,000 patients, I think about 1,000 different journeys that these patients had ended up in theater. Some patients are in theater because of complications of BPH, just to name one, chronic and acute urinary retention with an indwelling catheter, but others come into theater because their bothersome symptoms are refractory to medication. Other patients may end up in theater because they can't tolerate the side effects of medication. Incredibly enough, not in theater because I stopped these patients before they come into theater, but in my outpatient clinic, I often see patients who are referred to me for surgery for a simple reason, a large prostate. And I don't think that this is a good indication, but it is amazing that even nowadays, with everything we know about BPH and LUTS, patients are still referred for surgery only based on their prostate volume. Now, a few years ago, I developed an interest into help-seeking behavior, which is the reasons why patients seek help. And they seek help for many different reasons, and I think that we have to understand what brought the patient to us for a consultation. It depends on patient personal belief, whether they like me or not as a physician or as a doctor, or whether they like you as their treating doctor. It depends on their social and economic status. It depends on their race, on their culture, on their education, whether they are aware or not that treatment is available. Some patients are shamed about their condition. Some patients have a problem with BPH because their relationship is bothered by their condition. So please consider and keep in your mind that there are many different reasons why patients end up in our consultation rooms and finally in our theaters. Then again, when I think about a patient that used to be, when I was very young, a single entity, this single entity is actually made of many different phenotypes. I have young patients, I have obese patients like you have, patients with comorbidities, patients on co-medication. My brother is a cardiologist and I'm flooded with patients who had a myocardial infarction and they are on 10 to 12 medications. We all have elderly patients, then we have frail patients, then I have a special category, maybe it's only my personal category, but I get a little bit nervous when patients are over the age of 90. But I think that all of us now had these kind of patients brought to us by their daughters and sons saying, Dad is in very good shape. And I'm not very sure about that. When I was asked, what's the learning curve for the green light laser, which I, in a way, pioneered in 2005, I always answer with this example. It depends on who's your patient. And I think you all will agree with me that if the patient is your colleague, it's a little bit nervous. If your patient is your boss, it's different. I did therapy on my boss, and I was nervous. But the patient can be your dean, your rector, the member of the parliament. And living in Rome, it could easily be the president of the republic. And you would agree with me, I hope, that your learning curve also depends on the kind of patients you are going to do the surgery upon. So it's not always easy. When talking about BPH surgery, I have, as a surgeon, lots of concerns. I'm not sure, but my personal belief is that every patient should fail medical therapy before he ends up in theater. I'm not sure everybody agree. Sometimes I believe that my patients end up in theater too late, that maybe this delay is harmful for their health, and maybe their outcome is not going to be as good as if we had done the surgery up front. Obviously, there are other concerns that regards the surgical techniques. Do we really need minimal invasive treatments? I've gone through most of them over the last 30 years, and some of them, most of them, I would say, disappeared. And so I'm not sure that we really need those, whether it's the industry that is trying to impose them on us. I'm not yet sure how much debulking we need to do. I started as a young student doing open adenomectomy. So we are taking the whole tissue away. And then we ended up doing interstitial laser coagulation, taking no tissue at all. So the issue of debulking is still open. But what we don't know is what's the relation between debulking and durability, and between debulking and invasiveness. But this is a picture with a surgeon and a patient. So there are lots of issues relative to our patients. I have lots of patients with indwelling catheters, and we all know that there are more complications in these patients. Then we have patients with the true surrounder activity, something that we didn't even consider 20 years ago, but now we are getting more and more aware of it. We all have patients at high risk for surgery. And then I have lots of oncology patients who have an indwelling catheter, and they come to me and say, listen, doctor, I'm going to die in 3 years, but I don't want to die with the catheter. Can you do something about it? And obviously, the picture is totally different from a 50 years old man in good shape. But the patient have lots of concerns. Number one, continence. They're scared to death to become incontinent because of BPH surgery. Overall, they want to preserve the sexual function and their ejaculation. I understand women don't understand why men have a fixation about ejaculation, but that's a fact. Now, obviously, when I discuss the surgical technique with my patient, it depends on what they want. It's not that I always do what they ask me to do, but their preferences are of importance. Likewise, their comorbidities, their risk for anesthesia, their prostate size. Somebody wrote in what used to be AUA News that the real problem with BPH surgery are large prostates, not the small ones, and I couldn't agree more. The other point is whether the patient is willing to accept the consequences of surgery and the risk that any surgery carries. Obviously, as a surgeon, I don't have everything available. I'm trying to get as much as I can in terms of technology and techniques, but you have to rely on what you have and on the experience you have. And going back to doing the surgery on a rector, would you go for a novel technique or would you go for a standard old-fashioned TURP or HOLEP, whatever you feel like is best in your hands? Now, this is what the EAU guidelines tell us. As every guideline, not that much. It tells us which are the procedures that are between quotes approved, and a little bit of guidelines about process sites and what is available in terms of evidence in the peer review literature. But there is something that I'm getting interested into more and more as long as I get old in this job, which is patient positioning. The guidelines usually don't speak about patient positioning, which is about which patient will benefit most from a certain procedure, and the reverse, which is the best procedure for the individual patient. This is sort of a science or an art, I'm not sure, but I know that there are groups that are now trying to work on the issue of patient positioning, which is, in my view, the missing chain between guidelines and what we do in our daily practice. Another issue of importance that we have to consider is how do we measure the outcome, because we know that depending on the parameter that we use to measure the outcome, our success rate may change dramatically. Probably the patient is more concerned about his symptoms and his quality of life. Some of us are very fond of blood diary also as an outcome measure. We as urologists always use flow rate, but patients don't care about flow rate. They don't care about the PVR. They don't care about the pressure flow study. So we really have to think about the way we judge our outcome when we follow up our patients after surgery, because there is no agreement about this. This is just an example. I'm not saying that the BPH6 is the gold standard, but I like the approach. They put together symptoms, the recovery experience, erectile function, ejaculatory function, continence preservation, and safety. And I think that I like the idea to combine different outcome measures if we really want to understand how good a new technique, a new technology, or ourselves are in providing proper surgery for BPH patients. This is another one of my obsessions, quality measures, because at least in my country, this is a black hole. And I'm afraid that if we don't develop our outcome measures for functional urology, somebody will come and impose them on us. Give an example. Shall we measure the quality of the work we do based on the complications, on the need for the patient to come back to the emergency room, on redo surgery, on the need for BPH patients to have again medical treatment following, for example, a TRP? In cardiothoracic surgery is easy. The quality measure is death. In functional urology, it's not that easy, but I think that we need to put ourselves at work to come up with a good proposal. No doubts, this is a very simple list of what is available. As I said, usually none of us have everything available, and none of us have everything available with the same degree of experience. But this is really your individual choice depending on the country you work in, on the healthcare system in which you work. Big question, when to do the surgery? Vela Navarrete from Spain was the first one to raise the point when he looked into BPH cohorts 10 years apart. He realized that the prostate volume of the prostate that he was operating in 2002 were larger than it was in 1992 because of medical treatment, because nowadays very often patients end up in theater after many years of medical treatment, and sometimes the prostate keep growing in the meanwhile. This is another example from Korea, and they stratified patients between the pre-medication area, the time in which medication were introduced, and the time in which medication use became prevalent with respect to surgery. And what happened? Easily to understand. The complications rate increased in terms of hypertension, diabetes, previous operation history, and other type of complication. And the prostate volume, as you can see, increased. So we're not dealing with the same patients that we were dealing with 20 years ago. Is that important? Well, this paper from Meyer suggests that if you compare the old MeBust database with a more modern series, the number of patients who failed to void after surgery nearly tripled. And this is a concern because in the end, this is a decent outcome measure. We do the surgery to make patient able to pee again, and if we increase in modern times the number of patients who are unable to void, maybe there's something wrong in the way we manage our patients. This is another example, the VA study from Flanagan. When he compared early versus delayed TURP, what happens is very simple. If you operate the patient early, you have a better improvement in symptoms, you have a better improvement in flow rate, and you have a better improvement in post-void residuals. So delaying surgery, although I understand that the evidence is somehow weak, but this is what we have. We don't have any better study than this, but delaying the surgery may not be necessarily a good thing. And this is a good example of why this could be true, because if we look at the patients who failed to void after surgery, and we look into the electron microscopy of that detrusor, there are more abnormalities in the patients who failed to void compared to those who were able to void after surgery. So again, we know that obstruction may put the detrusor in danger, and this paper alludes and points in this direction. Another important issue, not for us, but for our payers, is that if we keep going with medical treatment for many years, about 10 years down the line, the cost of surgery equals the cost of medical treatment. So delaying surgery doesn't necessarily mean that we save money for our NHS. Another important issue, acute urinary retention. Ideally, I don't like to do surgery on patients with an indwelling catheter because I know that the infection rate is going to be higher, the complication rate overall is going to be higher. And these are data suggesting that patients who had acute urinary retention before surgery are prone to more TR syndrome, surgical revision, risk of UTI, failure to void, and even mortality. So ideally, we should get the patient in theater before he goes into retention. Next question is how to do the surgery and how much to resect. And again, the EAU guidelines, likewise the AUA, are not very helpful. We know from the HOLEP study versus TRP that HOLEP is better than TRP in the long term. Whether the differences that are obviously statistically significant are also clinically significant, it's hard to say, but every single parameter gets better with HOLEP compared to TRP. Well, if we compare HOLEP with open prostatectomy, well, the outcome is exactly the same. And without doing much statistics, I feel very reassured when I do a HOLEP that I will get more or less the same outcome that I used to have 20 years ago with open prostatectomy. Then the green light came in. I always try to explain my patients that the design of the Goliath study is a non-inferiority. It's not a superiority. It's just a non-inferiority. Numerically, as you can see, the results are slightly inferior to TRP, but from a statistical standpoint, there's no difference whatsoever. The interesting thing about the green light in this study is that overall, in this European study, 48% of these patients could have been discharged the next day. And this is a difference. There are not many surgical techniques that make us able to discharge a patient on the next day. And we know from experience, for example, at the King's College in London, that at least 1 in 2 of our patients could be discharged the next day using prostate vaporization. We don't have many data about how much we have to resect. This is an interesting study alluding to the fact that the only difference, depending on how much tissue you resect, 1/3, 2/3, or the whole adenoma, is in the PSA value post-op. Everything else, symptoms, quality of life, and nocturia are exactly the same. So unfortunately, the question is still open. Can we do a simple channel TRP, or do we want to go for HOLEP? Do we want to resect the entire adenoma or not? Now, toward the end of my talk, I would like you to concentrate on 2 paradigms that are important, at least to me. The first one, post-op delirium. When I ask my resident about, do our patients have delirium post-op? Everybody said, no, we are not a psychiatry department. But they do have delirium. And what this study from China suggests, that the odds ratio to have post-op delirium that, as you know, it lasts 1 to 4 days, and sometimes it's quite a problem in managing our elderly patients, is age and pain. We cannot do much about age. I can't get my patient younger, but I can take control of the pain. Pain control in TRP is important because the pain in a TRP cohort of patients is associated with the risk of delirium. And explain your resident that delirium is there. It's one of the things that I didn't think about 30 years ago, but now I'm more and more aware that the psychiatric disorder of our patients, these are normal patients, they are just old. But this is the last thing that I want to bring your attention to, frailty. This is the definition by Freud, who is the one who developed the first questionnaire. In order to be defined as frail, you need to have at least 3 of these 5 parameters: unintentional weight loss, self-reported exhaustion, weakness, slow walking speed, and low physical activity. At least in my practice, I have more and more frail patients. We've been talking about frailty in incontinence, but we have never been talking about frailty in TRP because this is supposed to be something for younger patients in better health. One concept that I want you to bring home is that, as Freud said clearly, frailty is not aging, frailty is not disability, frailty is not comorbidity. What these mean is that not because the patient is old, it has to be frail, not because it has disability, it has to be frail, not because the patient has some comorbidities that it has to be frail. So how to measure frailty? There are many different scales. I had a chat with Adrian Vac last night about their Edmonton scale of frailty, but I'm a urologist with a busy practice, so this is what we use. The time up and go. And don't tell me that you cannot do this in your office. You just ask the patient to sit on a chair, get ready to stand up and walk 3 meters, turn around, come back and sit. If it takes less than 10 seconds, the patient is okay. If it takes between 10 and 15 seconds, the patient has a condition called pre-frailty. If the patient takes more than 15 seconds, the patient can be defined as frail. And I think this is a very easy, it takes 30 seconds overall, way to measure frailty. But why I want you to get an interest in measuring frailty? Well, first of all, because if you look at the different patient cohorts with aging, the percentage of frail patients is increasing. It is true, below 65 years of age is a minimum number of frail patients, but at least in my practice, we have many patients over the age of 80, and as you can see from the dark bars, the frailty prevalence is increasing. But again, who cares? Well, we have to care, because these are data showing, if you look at the bottom line here, the TRP box, that if a frail patient undergoes TRP procedure, there is an increased risk of complication, there is an increased risk of discharging the patient to an assisted facility. He can't go back home, he's unable to go back home, and there is an increased risk of mortality. I know that when we talk about mortality, everybody says, well, TRP mortality is very low, and I agree. But being unable to discharge the patient home is a problem for me, and I guess it's a problem for all of you. So I want you to consider the idea to look more carefully about if your TRP patients are frail, because this is getting more and more important nowadays. So trying to improve the surgical outcome in my department, we screen for frailty, we screen for malnutrition, we screen for functional status, exercise tolerance and dependency on activity of daily living, and for cognition. Remember, some of your patients are pretty okay before they go into the emergency room. Then if they stay 2 or 3 days in the emergency room, once they come up into the department, their cognition is much worsened. And their relatives will tell you, but Dad was okay before he came into the hospital. And this is what happens when patient is hospitalized. So in conclusion, I do believe that the problem we have to face when dealing with BPH surgery is mainly managing the large prostates, trying to adapt the surgical technique not to us but to the patient needs. BPH surgery is not easy. The learning curve for TRP has always been told to be long, and it takes the same dedication that we have for learning robotic surgery. But doing the procedure is not enough. The most important thing is mastering functional urology, learning, loving functional urology. Do lots of cases, master the standard technique in your department. In my one, the standard remains TRP. Offer alternative treatments whenever this is available. And remember an old saying, all new treatments work miracle just for a while. This is a change I had over the last 30 years. When I started, I thought that the major, most important thing was the procedure. Then I learned that the preoperative evaluation is the key, as well as the post, because most of my complications occur in the postoperative period and never in theater. This is a change I made, and I think that some of you may have the same experience, and I wish to thank you for your attention, and I thank again the ICS committee for giving me the honor.
Thank you very much, Professor Tubaro. We have some time for questions. please. Is there any question from the floor? Yeah, Rico? Oh, well, there was a nice presentation indeed. Certainly, Remigio Vela said years ago that maybe now what we are doing with the medical therapy is doing surgery later, but But my concern, taking into account the data of the upstream study, is what are the indications for urodynamic investigation for BPH? Do you think that because it turned out that it doesn't matter according to the upstream study, right?
Well, I would say that on a routine base, we don't do pressure flow study in our BPH patients. We only do it whenever something doesn't make sense in what the patient is telling us. Unfortunately, we know that even if you don't do urodynamics overall, the outcome of your patients are going to be more or less okay. I'm interested in the truthful overactivity and underactivity because I know that from a quality of life standpoint, at least 25% of these patients won't be happy. And the patient may well accept this. But I want to be able to tell the patient, listen, you have severe urgency. There is a risk that your quality of life won't be as good as you would like it to be after the surgery. So it's about counseling. I don't think this is going to change the outcome of the surgery.
Okay, thank you very much. Oh, you go.
Rob?
Yeah, go ahead. Yeah, last question.
Andrea, thank you so very much for the presentation.
Well, thank you for the singing.
Thank you. But it was very nice as always and thought-provoking. You mentioned very briefly underactivity.
Yeah.
And as far as I can see, there's an emerging body of literature showing that these patients with underactivity do worse after TURP. However, there was a well-conducted American paper that I shared the day before yesterday showing that perhaps we are a little too concerned about this. More than half of the patients with underactivity, they got CIS-free or catheter-free after. Perhaps you can shed some light and share your thoughts about this.
I couldn't agree more with you. There is a politically correct trend now to say that if the patient has the detrusor underactivity, he doesn't need the surgery, which is wrong. Some of our patients have a weak detrusor, but they benefit from the surgery. Obviously, we have to warn these patients that the procedure is not a miracle. They won't be back to 20 years of age, but some of them, as you mentioned, get rid of the catheter. And the other point is, if I have a relatively young patient with a weak detrusor and his prostate will grow in due time, he will get obstruction. We won't be able to measure it because we measure based on the amount of pressure generated by the detrusor, and if the detrusor is weak, we won't be able to diagnose it. But these are the patients in which surgery may help. It's the same issue as doing TRP in patients with Parkinson. It's not for everybody, but some patients do need TRP, even if they have Parkinson or if they have a weak detrusor. Not everybody. We need to be aware of this. I'm in trouble.
No, I agree. I just want to make, Jerry Blavis from New York, I would make the statement stronger. Our data has shown in other people is that the success rate is just as good in TURP after underactivity. The difference is, so the success rate with respect to the patient's perception of how they're doing, the only difference is after surgery with underactive bladder, they tend to have a lower flow and a higher residual, but the clinical results are just the same. So I tell the patients that they have a high success rate.
I fully agree with you, but I didn't dare to be that straight. You are Jerry Blavis. You could do it.
Well, you're 30 years, I'm 40 years. When you're 40 years, you'll say what I said.
Okay. I will, for sure.
Thank you very much, Andrea. Thank you very much.